And the session today is part of a series of webinars that support clinical care management, or CCM. CCM is the largest quality improvement initiative that we've ever undertaken in the province of BC, so we're quite excited by it. It's led by a steering committee, and that consists of representatives from the BC Ministry of Health, as well as from all the health authorities, and it's supported by the BC Patient Safety and Quality Council. And for those joining us from outside BC, I wholly welcome all of you, and I hope that you can find something on the call today that's useful and can be applied cross-province. Part of clinical care management involves a movement to improve care for critically ill patients, and we've chosen glycemic control as the first provincial improvement initiative for this area of focus. And this webinar will focus on the BC ICU Database, which is an existing database that we're going to be using to collect data both for overall critical care improvement in the province of BC as well as for clinical care management. So on our call today, I'm just going to quickly introduce our presenters and our panelists. We have Shelly Fleck, who is currently the Director of Clinical Business Operations, the Surgical Program and Maternity Services at Providence Health Care. And for the 10 years before that, she was the Regional Analyst for Critical Care Medicine at Vancouver Coastal and Providence, and the Central Database Administrator for the ICU Database. And in this role, she collaborated with clinical experts from each of the health authorities and site-specific ICUs, and was responsible for the ongoing development, implementation, and training, and the analytics for this database. We also have speaking today Dr. Dean Chittock, who trained as a respirologist following a critical care specialty. He received a master's degree in clinical epidemiology at Harvard, and he's a practicing intensivist and the previous medical director of the Vancouver General Hospital Intensive Care Unit, as well as the previous division head for critical care medicine at UBC, and he's the current medical director for critical care at Vancouver Coastal Health, as well as the senior medical director at Vancouver General. We've got several people as panelists today that will be helping us answer questions. We have Dr. Juan Ronco, who's a respirologist, associate director, and an intensivist at Vancouver General. In addition to his active practice in critical care, he's the clinical leader for critical care improvement with the BC Patient Safety and Quality Council. So we work together to support the critical care area of CCM. We also have with us Dr. Peter Dodick, who's an intensivist at St. Paul's Hospital and a professor of medicine at UBC, and he's been instrumental in the development and the spread of the ICU database. And joining us as well from our council is Jill Wienendahl, who's a quality leader, and she focuses on measurement and evaluation with our council, and she's an active member of the Canadian Evaluation Society, and she supports the quality improvement measurement side of clinical care management. So I've asked her to come in as panelist to help us answer some questions later in the call. And if you're just joining us, you'll notice that all the lines are muted when you come into the call, and that's just to decrease feedback when the presenters are talking, but we will be able to unmute you if you ask questions later during our question period. So before I hand it over to our first presenter, I just wanted to get a quick sense of who's joining us on the call today. So we're looking at a map of our BC health authorities, and it's in the top left corner of your screen, you'll all notice an arrow, a small arrow. Click on that arrow and point to the area that you're calling in from. And that gives us a sense of where people are calling in from, where you're joining us. Great, so I see lots of people from the interior today. I see some people from Prince George. Hi there, Beth Ann. See some other people, I think from Vancouver Island. So, and I see that we have someone joining us from east of British Columbia. Hi there, Bruce. You can see your arrow. And it looks like as the minutes tick by, we're getting more and more people logging on to the call. So it's great. We've got a lot of people joining us today, so it's going to be a great discussion. So while the presenters are talking today, if I can just ask everybody to ask questions with using the chat feature to begin with, and then later on when we hold time, we have 10 minutes that will hold the lines open for questions, and we'll be able to unmute you then. So the first way to ask questions, if you think of a question while the presenters are talking, type it into your chat feature, and you'll see that on the right-hand side of your screen towards the bottom. There's a chat feature. And I'm just going to type something in so that you can see what it looks like. Okay, so as the presenters are talking, just feel free to write down your questions and press send. And when we have our question and discussion period at the end of the call, I'll be able to read out those questions that have come up and direct them to the right person on our panel. And during the question discussion period at the end of the call, there's a second way to ask questions. And you'll see just above the chat feature at the bottom of the participant list on the right-hand side of your screen, you'll see a virtual hand symbol. And if you click once on that hand symbol, you will put up your virtual hand, and I will be scanning for those during our question discussion period and calling on you and unmuting your line so that you can speak to our panelists and ask your questions directly. So just to quickly run over some of the objectives today, we're going to learn about the history and development of the BC ICU database. We're going to understand the overall structure and how it's administrated. We're going to hear a brief overview of the type of data that's collected, and we're also going to review the use and the benefits of that data for quality improvement, specifically in the critically ill population. So I'm going to now pass it over to our first presenter, Shelly Fleck, who will be talking a little bit about the history.
Thanks, Shari. So what I'm going to be doing is I'm going to be walking you through the first three objectives of the overall objectives for today's session. I'll be talking about the history and development of the database, the structure and administration, overview of the data, and then I'll be turning it over to Dr. Chittock, who will actually get into the fun part of the presentation where he'll show you how we've used the information that's in the database. So currently we have 4 health authorities that are using, or three health authorities and PHC as its own entity, who are using the database. We have Vancouver Coastal, Providence Health, Fraser Health Authority, and Northern Health. The history of the database, it was a joint venture development between St. Paul's Hospital, Vancouver General Hospital, and Capital Health Region, which is now VHA, back in 1997-98. And actually, Dr. Chittock and Dr. Dodak were the developers of the database, and they really got the whole process started. The initial goal was to create a minimum data set using a client-server design, and the purposes at the beginning of the process, and they hold as being our purposes even today for the database, are to identify opportunities for improvement in care, utilization management within the units specifically, and then across health authorities and certainly provincially, and to enable research related to health services and outcomes in the ICU. From a research perspective, we still look for ethics approval, and we follow all those processes that are required for all other research-related activities throughout health authorities. The database has evolved since 1997-98. It was initially implemented in 1999 at St. Paul's Hospital, and in 2000, VGH started using it. And then over the course of the years, other sites have come on. Now, we've had two major developments of the database, or reworkings of the database. In April 2006, we redeveloped the database somewhat because we added 6 additional screens to cover patient safety measures, and that was in relation to a study that Dr. Dodak received funding for. In January 2010, we did another complete screen redesign, and with all the sites that were on the database, we just thought it was the ideal time to really clean it up a little bit and make it easier for new sites coming on, breaking it out into what was a minimum data set versus optional data set. And in April 2012, we will have another slight modification of the database as we start adding CCM data requirements, capture requirements within the critical care units. Current users of the database, as I've alluded to, 1997-98 were development years, 1999 St. Paul's, 2000 Vancouver Coastal, 2002 Richmond, 2005 Lionsgate, 2006 Mount St. Joe's. In 2006, 4 of the Fraser Health sites joined the database. In 2008, the Royal Columbian High Acuity Unit and Powell River collected for a year. And in 2009, the remaining Fraser Health sites came onto the database. In August 2009, Northern Health Prince George came onto the database. The structure of the database, it is a web-based database, therefore there's no copy of the database on local computers. Everyone accesses the database through the internet, through an IP address. It's an Oracle program database. We do use existing structures where possible in the database. So for example, when we identify physicians, we use their MSP billing code. We do use the Chi-Hi service tables where we capture service-related information. From a diagnosis perspective, we do not use ICD-10. We are using ICNARC, it's called, and it's a diagnosis system that comes in collaboration with the Apache tables. And then we also use ICU-specific tables, things that we've created specific to activity within units that we want to collect. So it's procedures, arterial central lines, and then some of the optional data screens that I'll get into in a few minutes. From a privacy perspective, the database is housed on a server located within the CHAOS group at Providence Health Care. CHAOS is the research entity out of Providence Health Care. Each site has a site-specific dynamic view, meaning you can access and view patients specific only to your own ICU site. So even across health authorities, sites cannot see other sites' information. If I'm at VGH, I can only see VGH information. If I'm at Royal Columbian, I can only see Royal Columbian information. There's 2 levels of sign-on authentication. There's a unique password for each user. There is a forced requirement to change the password on a regular basis. And in situations of failed attempts to sign on or an idle time where you stepped away from your computer for a period of time, it will lock you out and you'll need to log back on. There is the ability to audit the database access by both date and user authentication. We have gone through a privacy impact assessment, and we are opening up that process again as other health authorities are interested in or expressing interest in joining the database, just to make sure that we've got all the privacy angles covered. From an administrative perspective, there's 3 people who can access all databases across all sites. It's the Senior Database Administrator from CHAOS, there's the Database Programmer, and then there's the Central Database Administrator. And the reason all 3 of these people need to access the sites is we basically troubleshoot from the back end when sites call and they have problems either getting onto the database or there's problems with their data, they've entered data incorrectly, things like that. We've built in security measures along the way so just not anyone can go in and access basically any of the database structure. There is a comprehensive data dictionary that accompanies the database. The majority of costs associated with the operations of this database is primarily ICU informatics staff. On all the sites, these are ex-ICU bedside nurses who are doing the data capture. They are responsible for editing their data at period end, and as well, we've built a limited amount of online edits. There's minimal IT support costs because we're working with the CHAOS group, and the analytics are really health authority dependent. So initially, when sites came on the database, I provided the analytics for the health authorities. However, Fraser Health has since come up with analytics out of their decision support area, and Northern Health, I understand, is doing this as well. But certainly if new sites, new health authorities are interested in coming onto the database, we will work with them and transition analytics to them when we can. But certainly we do realize that to capture data, you have to be able to report it as well, so we provide that service. From a database content perspective, we've split the database into 2 categories. There's a minimum data set, which if you're going to use the database, this is what we recommend all sites collect at minimum. So it's your basic demographics, visit information, ICU and hospital, admission information, discharge information, outcomes, diagnoses, interventions, some severity of illness, scores, and then level of care, overflow, and avoidable days. And I'll get into this a few minutes later when we show you some of the screens. And then the second component would be the optional data set. Now these are data screens that if you have the resources to collect the information in your unit, you can do so, but you can pick and choose what you collect, and it really is resource driven. So if you have the staff to collect all the information, then go ahead and collect all the information. But if you only have limited resources, what we would suggest is you start with the minimum data set first and then build on that as resources increase or the informatics staff get more proficient in the job. The data capture guidelines, it's primarily concurrent capture. So while the people are in the units is when we capture the information. It's not on discharge from the unit and it's not on discharge from the hospital. We capture information for every day that the patient is in the ICU or, in the case of an overflow situation, under the care of the ICU team, and it's based on admission to the unit. Algorithms are built in based on data capture. So, for example, the Apache scores, we have the informatics people just enter the lowest and highest values for each of the elements used in the Apache scoring, and then we've built in the algorithm behind the scenes to actually calculate the Apache. We've built in some smart designs, so if initial criteria is not met, then there's no need to land on associated fields. There is some synoptic reporting ability. We have very limited free text capabilities, so in that way, all the data going in is standardized as well as coming out is standardized. And we do have the ability to capture all patient admit types within the ICU setting. So they're off-service ward admissions, whether they're a high acuity unit or an ICU or a progressive wean unit, for example. Whatever the units have, that is what we have the ability to collect in the database. Just very briefly, some screenshots of the database. So this is what you would see the first time you log on. This is where you're calling up your patient. So if it's a new patient, you know you've never been in the unit before, you enter all the demographics on them. However, if it's a patient that you're not sure or you know they've never been in before, or you can enter the query and see if they come up. If you look at the bottom of the screen, this record was last saved by and this record was last viewed by, so we can always see who's in the record or who the last person was in the record. And then this is where the visit information comes in, hospital information and ICU information. From a hospital perspective, all we really care about when we look at it is we care about when they were admitted to the hospital and when they left the hospital and what their disposition was. Other than that, the database is primarily concerned with what happens to the patients while they're in the ICU and or under the care of the ICU team. And then from an admission perspective, these are all the fields that are related to patients as they're admitted to the unit, so where they're coming from, by service, by ward, their physician. If they're coming from eMERGE, you can see we have some information that we capture on them. If they come from an outside facility, we capture information on them. So this is what I spoke about a few minutes ago from a smart design. So if your patient is admitted from the emergency department, then you're not going to land on if they came from anywhere other than the emergency department. You would just capture that information on that patient. The next screen is discharge base. This is all the information we capture on them when they are discharged from the unit. So if you're from a database perspective, these are the 4 screens that you would capture on everyone coming into the unit. This is just your basic front end of service identification of patients in the database and subsequently in your units. Then what we do is we get into the minimum data set, and as you see across the top, these 8 tabs, we capture diagnoses, procedures, central arterial lines, the conditions, physiology 1, physiology 2, and 3. Those 4 screens are related to the severity of illness measures that we measure. Overflow, those are patients that are sitting outside the unit but cared for by the ICU team, level of care. From a procedure perspective, we do not use procedures as outlined in the CCI. What we do is we capture procedures that we find are intensive, either resource intensive or cost intensive in the ICU. And we split these out according to mandatory procedures versus optional procedures. So mandatory procedures are anything ventilation related, road trips in and out of the unit, dialysis, whether it's kidney or liver dialysis, feeds including TPN, and then ICU specific or resource intensive procedures such as EVDs, TEEs, chest tubes, you can see there. What we do capture for all the procedures is we capture the duration of time while the patient is in the unit. So for patients who are mechanically ventilated, we know down to the minute unit, how long they're ventilated. For people leaving the unit on road trips, we know exactly when they're leaving, when they're coming back, where they're going, so we can do some analysis on activity in and out of the unit while they're actually in the unit. And then optional is just things that sites feel they want to collect specific to their own site because it might be a resource issue or they're trying to build a case to get additional resources. So from an optional perspective, you don't need to collect this information on a forever basis. You can capture it for a 3 or 6 month period and then analyze it and stop it. Central lines, we capture all central and arterial lines that the patient receives while they're in the unit, so we capture it by the specific type of line and the side, right or left, if it's a CVC, how many lumens, and if the line was put in prior to admission to the unit or whether we put it into the unit ourselves. We use line days in collaboration with infection control to come up with our BSI rates. And then from an overflow perspective, these are patients that are, as I said earlier, they're sitting outside the unit, physical unit, but cared for by the ICU team. So we capture where they're actually sitting when they're there. So if they're sitting in emergency prior to their admission, for how long, or sometimes if the units are extremely busy, we will actually transfer patients out of the ICU into the PA or CCU while we get the most sick people in the unit. So we can capture that as well. So it is a real reflection of just what our overcapacity is as an ICU. And then level of care, for every day that the patient is in the unit, we capture at the start of every shift what their level of care is. And it's not how many nurses they should have, but basically it's an objective measure that measures where this person is at from a level of care. And then the severity of illness, as I mentioned earlier, the conditions physiology 1, 2, and 3 screens are the ones used to capture all elements related to the Apache 2 and Apache 4 screens. And then what the informatics people do is they can calculate the score as soon as they've entered the information, and they can actually go to the next screen that will actually print out for them what the score and their probability of death as well as what their predicted length of stay is for that patient. So that's the minimum data set screens that I just walked you through. And then the optional data screens, we're running a bit short of time, so I'll just take the next minute just to, at a very high level, these are the screens that, as I said earlier, if you don't have the resources, these are the ones that we would say, you know what, well maybe you won't collect these ones to begin with until you can either find more resources or the people you've hired or have gotten quite proficient in capturing the minimum data set, and then you can pick and choose which of these screens you can collect. We have built, again, so that the informatics people review the chart for the entire time they're in the unit, but they only actually enter data if criteria is met. So for this particular screen, SID difficile diarrhea, if the patient never has diarrhea, and as defined by an acute onset of diarrhea, as you can read here, then we would never enter anything in this screen. However, if they did meet criteria, then what you would do is you would enter the date and you would go through to enter the information, you would press calculate, and it would tell you whether the case is actually a confirmed case of C. difficile or not. And so what we've done is we've built that into most of the screens here. For vasoactive drugs, this screen is just, we're simply capturing for every day the person's in the unit if they're on pressors, and if so, what they are on. Blood utilization, we capture select blood products, and again, for how long they're receiving the products. The SOFA score is an organ function score that we capture for the first 7 days the patient is in the unit. The TRIS score is a trauma score that we capture on trauma admissions. And then the optional data screens we've started capturing delirium and RAS and a VAP bundle, and we're also going to be starting to capture the glycemic index screen once we have finalized the structure of that screen. So at this point, I'm going to turn it over to Dr. Chittock to talk about how we've used data from the ICU database. Dean?
Thank you, Shelly. I think everybody can hear me okay. I'd like to start with, I'm really going to be going through the last objective of this presentation. And I am going to apologize up front for, really I'm using largely a Vancouver General Hospital data. That's mostly for my own purposes. I'm familiar with it, and however, I'd like to emphasize that what we present through that unit is simply can be transferred and done anywhere, and has been done in many other sites. So I'm really going to talk to you today about the application of the database to a quality improvement program. And about the use specifically, how we focus on going through that from a quality lens throughout the ICU spectrum of care. And what I want to emphasize also is what the database actually represents. There are lots of different databases, administrative databases and the like, but it is really a core and necessary precondition for the implementation of any quality program. And specifically, it's a prospective cohort database that's very ICU specific, rich in clinical data that is representative of our ICU population, and therefore makes it a very fertile ground for this kind of work. There are, as you can see here, many different uses for this type of database. Obviously, we're going to emphasize the patient quality safety initiatives and quality improvement that can be implemented under this realm, but it's also useful for many other things that really have a quality bent to them. There's a clinical management of either at the unit level or even a health authority or at a provincial level, utilization management for the same. You can look at it from both internal and external users' perspectives with regards to performance. Use it to help you manage your staff. Certainly very useful, and we'll talk about later, tests for care delivery. If you change processes, treatments, or models of care, what effect that might have on your population. It's very useful for planning, which I'll show some examples of. Collaboration with others, and that collaboration is not just with say other stakeholders. It's within your own institution. It can be between institutions as well as between provinces and countries. And finally, not to minimize the value for research, it's a very fertile ground for observational research, health-related and outcomes research, to which perhaps at the end of the talk, Peter would be able to answer some questions about. I think, though, that having said all that, we can summarize a lot of what we're talking about into three basic categories, and that is understanding the business. We can ask the question, how well are we doing? And then we can ask, can we do better? So it's with those three purposes in mind that we'll take you through the rest of the presentation. So, understanding the business first. This is a snapshot of really our ICU admissions at the Vancouver General Hospital over the time of the inception of the database. So you get a very nice view of what your business has been like just from volume utilization perspectives and how you've managed your resource with regards to things like access for care, et cetera. But just understanding the business is a very important aspect of the first parts of any database. Along the same lines, you can look at things like ICU occupancy over the same time frames. You can utilize this kind of data both within your own unit but also within your health authority or at a provincial-wide level to see how well we're serving, again, our patients. What does our business really look like? The other things that are useful up front with regards to understanding your business are understanding exactly how the data is generated. So this is an example of how the database can help you really understand exactly what you're up against. Many hospitals and institutions utilize administrative type data to give a picture of occupancy of various units. They will often use either a midnight census or a single point in time to look at somebody's census. We do know that with regards to an ICU where it's a very dynamic environment, midnight census may not be very representative of the business and of your true occupancy. The value of the database is that we actually measure our occupancy to the minute. So we have a real-time occupancy that can be generated and therefore can give us information that wouldn't otherwise be available to us about our uses. So, for example, if you use a midnight census, you can see the occupancies here by line. This is just over a snapshot of a month. They're considerably different with regards to the unit if you use a snapshot versus the real-time occupancy. And over a year, it can look like our occupancies within a health authority ranged from 85 to 95%, when in fact, if you look at this chart, for most of the units within the Vancouver Coastal Health region, we see occupancy that on average for Vancouver General Hospital is greater than its funded capacity, so over 100% for St. Paul's Hospital, similar story, 100% for the smaller units of Mount St. Joseph's, near 100% for Lionsgate Hospital, and over 100% for Richmond. And then if you look at the range of those values, you can see that sometimes our occupancies are quite high. So you get a much better feel for your business through real-time data. Other things that you can look at that we do often have a picture of what our activity is like. This is from 2003, 2004. When we looked at the different sources of our admissions, where do our patients come from? And, for example, 29 to 30% come from direct from the emergency room or direct from the operating room, 18% from the wards. And that was the sort of makeup of our business in 2004. You may then ask, well, has that changed with time? Here's a snapshot of the same questions from 2010, 2011. We can see that our business from the wards was 18% previously, has now risen to 25%. We've had an equivalent drop of our directs from the emergency room and a significant increase in our emergency admissions up about 37, 38%. So it can help you to ask questions about your business, but also inform you in ways that may help you to redesign the models of care if necessary. Further snapshots of what your population may look like. This is an age distribution for the unit and associated patient days with each age. We often ask the question, well, do the elderly patients consume more patient days than other age groups? And from this data, it doesn't appear to be the case. You may also want to focus on particular populations. Again, here we have a snapshot of our growing aging population that we serve. And looking at some of these trends, wondering if models of care within the ICU may need to be changed based on the populations that are changing throughout our years. This is another snapshot of the cases that we look after. This may be different by unit. Again, gives you a nice feel for the type of cases that you're looking after, everywhere from patients with severe ARDS, pneumonia, traumatic head injuries, septic shock, etc. And it gives you a nice picture of what you're dealing with. Length of stay is an important parameter we always look at in the ICU. Again, you can have pictorials such as this that give you a nice snapshot view of how your business is. Just quickly looking at this, you can see that if we go out to a week, almost 80% of our cases are through within a week length of stay. If you go out to 2 weeks, over 90% of the work is dealt with. But it also helps you to ask questions like, well, what about this population? What about this last 10% that are the long length of stay patients? Do they require a different type of care? What specific questions might you be interested in asking about that population? And the database can help answer those. I'd also like to know, obviously, when do we work? We were always surprised when we looked at this data, and it might help you inform on your resources. The busiest time for this particular unit happens to be after midnight. So do we have adequate resources in-house to look after this increased workload? Ask the same question about when do we discharge patients. This is a quality initiative and a quality improvement project waiting to happen. We've identified that we discharge patients from our ICU 10% of the time after midnight. That is not a planned discharge, therefore likely relates to our high occupancy and demand for the bed, but yet we know that patients that are discharged in an unplanned way have sometimes a poorer outcome than those who have a planned discharge during daylight hours. So it helps inform us on our business. Other ways to inform us on our business is we can look at our Apache scoring system and further look at it not just from an absolute score that patients come with, but what risk category do they arrive with. So it gives you a nice picture of your ICU. We can see less than 10% of our population have the low risk in the lowest 10th percentile. We have a significant number in the highest risk percentile. And then ask the question, well, how do we do in each of these percentiles with regards to observed versus expected outcomes? So the solid green bar demonstrates the expected mortality for patients within each category. And we can see pretty much in every category that we have greater than expected decreased mortality for each. But it may not be the case, and we may ask questions if this has ever reversed. What is it that we're doing to improve that then? And then we can combine those to give us a global score, a standardized mortality ratio. If it's less than 1, then we're performing well against a standardized population, and we track that by quarter. At any time it seems that we're out of range, we would make some adjustments to our care. The other interesting sort of picture you can paint of an ICU unit, but you can do this, as I said, at any level. This is a snapshot from a few years ago for the ICU at Vancouver General. Just in brief, it showed that we had a 90% mechanical ventilation rate, our overall dialysis rate at about 12%. This was always surprising to us when we first started to look at this. We had placed over 2,000 central lines. We certainly want to target our procedure outcomes with regards to central lines when you're putting in that many lines. 60% of our cases have a use of a vasoactive agent. We look at tracheostomies, most of which of our population that require it occur in the operating room. We do not have a service that provides it within the ICU, and that may change if you change processes of care. And how many patients go on a road trip are listed there. Our TPN rates, chest tube rates, and how many patients receive blood transfusions. These are just a few of the interventions that you can list to give you a nice snapshot of what it is you do. And then you can ask the question, well, how do we look compared to other jurisdictions? And this kind of descriptor can help you compare. So if we look at the literature, Craig et al. And Chest, in their recent publication, published benchmark data for more than 240,000 adults that reflects the current practice of critical care they felt within those units. There were over 200, 300 ICUs that participated in this. But they had a 27% invasive mechanical ventilation rate, a 24% vasoactive agent use, 20% blood transfusion use, and more than 40% had a less than 10% mortality risk based on the Apache scoring system. So based on this data, you might then look at your own unit and say, well, policies that come out of the U.S. that may be based on this data may not apply, therefore, to your own unit or to our Canadian ICU population. And it just helps inform us much more succinctly about our business. Just a little bit about the business. Let's move on now to uses of how well are we doing. And what are some of the problems that we might be able to identify with the use of the database that will help us to ask those questions. So I showed this slide at the beginning of the talk. As many of you may have noticed, we had at one point in the year 2004, 110% occupancy of our ICU. Data such as this helps us to build business cases and help to plan for future need for resources. And based on this data, we were able to expand the bed base of our ICU. Similarly, we asked the question when we first got this data back in 2004 or 5, is the length of stay in our ICU, average length of stay in our ICU of 10 days, is that really based on the severity of illness of the patients we looked after, which is what we assumed at the time? Or are our practices affecting this length of stay that we might be able to modulate and change? How did we do that? Well, we looked at others. We asked to benchmark across Canada what length of stay for similar type institutions might be, and we found ourselves to be an outlier. So that allows us to target improved things that may alter our length of stay. Along similar lines, We also had issues within the ICU in 2007 with regards to how long it would take us to transfer out a particular population, in this case, patients with spinal cord injury. They seemed to be waiting in our ICU for transfer once they were deemed to be ready to go for a prolonged period of time, therefore occupying an ICU bed unnecessarily. Other things that were recognized to be potential issues that the data brought up. This is data from our unit from 2004. And each of these, it's not showing up very well on my slide. I apologize. I don't think it's showing up on yours, but I'll go through it. Each of these are really areas from which patients come from into the ICU or admitted to. So the 15% mortality rate is from the OR, direct patients from the OR. 17% is direct from the emergency department on up to this 34%, which caught our eye, which was direct from the ward. And we asked the question, well, is that, again, just a function of the severity of illness of those patients, or are there programs we could put in place that might help mitigate that outcome? At the same time, we asked the question, well, does it matter what time or when patients are admitted to the ICU after a hospital admission? And clearly there does appear to be some relationship with length of time in the hospital to increasing length of stay and increasing hospital mortality. So it allows us to ask questions that we might be able to put quality improvement programs in place and then ask if we've improved those outcomes. Other internal things that we can look at, one of the things we're interested in is unplanned extubations. We're not sure that we should have any unplanned extubations, but we did at least set a target incidence of only 0.7 per 100 ventilator days. That's the blue line. We have not been below the blue line in the first 7 periods of our fiscal reporting time for this particular year. We did manage to get down a couple of times afterwards once we targeted what the issues may be relating to this event. But that's something you can track on an ongoing basis, put fixes in place, and see the effect of them. Same can be said for readmissions. Readmissions are not always ideal and may need to be addressed. We certainly follow those and target areas where readmission rates seem to be going up, ask the questions why, see if we can put in some improvement processes in place to mitigate that outcome. Other ways to help ask the question, how well are we doing, is you can look at involvement with others. So we participate in the Canadian Critical Care Vital Signs Monitor. It's a web-based national ICU reporting system that's been in place for some time. We report general outcome measures and patient-specific system process measures. We have 24 different sites, 5 different provinces participating with 20 different indicators. These are some of the indicators that we've gone through that we can compare and produce this kind of a result where you can compare like institutions to like institutions and see how well you're doing compared to the rest. So this is a very valuable use of the database for comparing against others in an external way. So moving on then, can we do better? One of the major, I think, functions of the database is asking that question. How can we improve? Let's test some ideas. So again, these are just a few examples of some of the things you can do. One of the major projects we put in place early on in the infancy of this quality program was changes to our sedation practices in the ICU. It was a simple implementation of a sedation scale in a randomized way, and then prospectively looking at the effects we had of that simple intervention on our mechanical ventilation days and our ICU length of stay. And you can see in both cases we had significant reductions in both the mechanical ventilation days and ICU length of stay just through the implementation of a sedation scale. Other questions that can be asked, one of them we were interested in was the implementation of an emergency department sepsis protocol and what impact that would have on the care of patients with severe sepsis that were ultimately admitted to an intensive care unit. And here we show a control year of which we had 40 patients that came through with diagnosis of severe sepsis and septic shock, to the comparative year after the protocol was implemented of 60 patients. And we were able to demonstrate in that cohort a drop in in-hospital mortality, decreased hospital length of stay, decreased days on mechanical ventilation, and a drop in ICU mortality that was significant. We had also implemented a weaning protocol, asking the same questions. This is, again, the same simple design for quality improvement of before and after comparison of what things can look like after the implementation of a weaning protocol in a unit such as ours, and compared using the database, the before the implementation data and after implementation data, and we're able to see a point estimate where there was an improvement with all patients with regards to decreasing the mechanical ventilation days. One of the other issues that came up, that questions arose from the database, was how long we were waiting for patients to receive a tracheostomy and those that were deemed to require one in our ICU. So we tracked the data with regards to tracheostomy hours, median days of mechanical ventilation, and both intensive care and hospital days. And then we implemented a specific targeted protocol that that we were hoping would improve this time to tracheostomy. And this is the before and after picture of after implementing the tracheostomy protocol. We were able to show a significant drop in time to tracheostomy from 31 hours down to 11 hours on average. And this resulted in a drop in our median days of mechanical ventilation. Our ICU length of stay and our hospital length of stay were significantly impacted by this protocol for that population to which it applied. So in the end, what are some of the solutions we can seek for some of these things that are highlighted by the database? I showed you this diagram earlier on, where we had a high mortality rate from the ward patients at 34%. One of the things we wondered about with regards to that outcome was whether we're getting timely and informed care for patients that ultimately became critically ill on the ward. And this data helped us build the case for the need for a rapid response team and critical care outreach team was formed. This is the data from the first year of that team, in which we demonstrated a good uptake with regards to visits. There are 131 patients per week being seen at this point in time after 6 months of implementation, so good uptake for the team. And that team was, post-implementation, we were able to demonstrate a significant reduction in our admissions to ICU following a code blue. So 42% of the ward population in the past came to us via a code call. We were able to reduce that to 36%. But even within this data, we can see areas of improvement. If you look at that 36% that still come to us via a code, how many of those patients were seen by outreach prior? And we can see that 68% of those patients still did not receive an outreach call prior to the code being called. And we view that as another area for improvement to target. Other outcomes from the implementation of the outreach team in a before-after fashion, we looked at time it took for the ICU to be involved post-ICU admission, and we were able to reduce that from an average of 8 days down to 5. We were able to reduce then also our ICU and hospital lengths of stay associated with the rapid response team implementation, and as well demonstrated a decrease in our ICU and hospital mortality subsequently. So then we asked, well, has we changed this graph? Have we targeted these patients well enough, and we'll need to further implement ways in which to get that outreach service implemented to see if we can further target these long-stay patients on the wards. So how well have we done? If we looked at what our results were back in 2004, I'll remind you the emergency room admits had a mortality in the ICU of 17% and our wards 34%. How has that changed now in 2011? We've been able to demonstrate a significant now reduction in those ICU mortalities from those locations, 13% for the ED admits and 21% for the ward admits. And we believe that's a direct response and result of the quality processes that we put in place equally so to talk to you about this result from the spine ICU. At the same time outreach was implemented, we also provided a different model of care for the spine ICU where intensivist care was provided to that population. Subsequent to implementing that initiative, we were able to demonstrate a significant reduction in time waiting for the transfer of those patients to the appropriate unit. So what's some of our evidence in conclusion with regards to continuous improvement? I showed this chart at the beginning. This line demonstrates the place where no further ICU resources were implemented. Despite no changes in our bed base, we were able to accommodate and allow for access of significantly more patients with regards to the demand, and think that is directly related to the implementation of these quality improvements that we put in place throughout these many years. And as such has also equally resulted in a progressive decrease in our ICU length of stay with a subsequent reduction in the overall ICU mortality of all patients that are served over those years. This is in association with an increasing severity of illness as measured by the Apache 4 scoring system. So in conclusion, I think we've demonstrated some of the uses of the database with regards to a quality improvement program, how you can actually ask questions and get answers about some of your implementations. We can't always be sure that our changes that we are observing are a direct result of our quality improvements, but the temporal relationship and the actual result that we, in the end, have improved speaks for itself. I think I've been able to demonstrate clearly how the database can be used for both patient quality and safety initiatives, but we've also touched a little bit also on its clinical management, utilization, internal performance indicators, and tests of care delivery, planning, and collaboration with others. I didn't touch on research. That's a whole other area of topic that perhaps we can bring back at another time. So overall, I think I've provided us, or I'd like to emphasize that the database provides us with an understanding of ourselves, our business, our performance, our outcomes, and the impacts of changes we make to our models of care. And it forms the basic infrastructure to allow us for a continuous quality improvement. For the future, I'd like to emphasize the need to integrate this database throughout our institutions, to be able to also then do some of this work between and within our institutions, within our regions, and ultimately throughout the whole province. And I think the knowledge exchange, quality of care, effectiveness, and efficiency that will result from that have a high potential to optimize the system-wide provisions of critical care services. Thank you very much.
That's great. Thanks, Dr. Chittock, and thank you, Shelly, for some great presentations there. I'm going to go now to sort of open up the phone lines and open up the floor for questions for either one of our presenters or any of our panelists. And to ask a question, you can either type your question into the chat feature, or you can click on your virtual hand. You'll find that a little hand symbol on the right-hand side of your screen. Click once on that, and I will be able to unmute your line so that you can ask a question for either of our presenters or our panelists today. Are there any questions for Shelly or for Dr. Chittock? We did see one question that came up, and this is a question that went privately to the host, but I think I can read it out anyways without the name associated with it. But the question was, is the expectation by the province that all health authorities will be using this database? I think it's something that we would like to encourage, because it would certainly make data collection for clinical care management easier, and in addition to all the benefits that Dr. Chittock described. But certainly there's no expectation currently that we can share this. And maybe I'll sort of ask my colleague Jill Veenendahl to comment on that if she could.
Well, I can try. I think from the person who is, I'm sort of accustomed to the one that gets these requests of how do you really want us to run these numbers, and if people on the call are familiar with the CCM data guide and with the indicators that are associated with the critical care measures. From my understanding, Shari, and correct me if I'm wrong, but there's been a lot of willingness with Shelly and the folks that are sort of administering the ICU database to put some of these the formulas into the database so that when you're putting your numbers in, it's going to auto-calculate the glycemic control indicators that we're looking for, which is just to create the hyperglycemic index, which is pretty fabulous in terms of a time-saving feature, and then also the ability to see in real time what you're looking at in your own individual ICU units, and not needing to send that off for analysis with anybody else. And I think I'm on there. So that would be my supporting argument, just from a CCM clinical perspective.
This is Shelly here, and I would just like to add that from a database perspective, and certainly from a structure angle, the database is very responsive. So if there's a site out there that wants to capture something that no one else does, we can certainly build a screen just for that site to capture the information. And as I alluded to in my presentation, once you start collecting, that doesn't mean you're locked in forever. Certainly you can collect for whatever period of time you like. You can stop collection. You can do some analysis. You can, come up with a new intervention or a new protocol, as Dr. Chittock spoke about, and then start capture again and do some before and after analysis. So the database is very responsive. We can program it to meet individual needs, or we can program it to meet everyone's needs. If everyone's going to collect the same data element, then we would standardize the definition across all sites. Now, referring to the glycemic index screen that we are in the process of programming and just testing, that's exactly what the screen would look like. Is sites would enter the blood sugar information for each of the patients, and then once all the data is entered, there's going to be a calculate button that you calculate, and it will show you right there what the glycemic index would be for that patient. We're going to have the index value, we're going to have the graph. So everything, we've really tried with the latest iteration of the database in January 2010 to really put as much stuff online as possible so that you can see right there when you're capturing the data what your outcomes are.
Great, thanks, Shelly. Any other questions?
I'll just speak maybe one more comment to the workload for data collectors. We have run some statistics on that and what we think it would look like to staff an ICU and informatics program within the ICU. And again, it really goes down to what you as the unit want to collect, whether you want to go with the full database or you're going to start with the minimum database and graduate to full capture. What we have come up with is that for every 12 ICU beds, full ICU beds in your unit, that we would suggest that you would need a 1 FTE informatics person. It sounds, it may or may not sound like a lot of people to capture information, but certainly in Dr. Chittock and Dr. Dodick can probably attest to the fact that it's certainly money well spent when you look at what you can do with the data and what you can do to look at exactly what your business is, where you're going, what you're doing, where you can improve. And as some of Dr. Chittock's data demonstrated, we've been able to make some significant savings on the VGH site just by looking at what we're doing, targeting a practice change, and then retesting again and seeing just what the outcomes are. So I would be, you can contact me after the call and I can give you more information around the whole workload related to the database. But it's certainly, it is money well spent.
And I just have a comment, Shari, if we have time. I can certainly attest to what people have told me, that, the newcomers that have come on the database when they've come on and not previously had a lot of this available to them. It's quite remarkable at how much you believe you understand the business you're in until you actually really look at it. And people just love to look at, how they're doing, what kind of business that it is that they're in. And then once they get through that, they then start to do even just small looks at how the data helps them inform their day-to-day practice. And remarkable new efficiencies can come out of that, both from that both administrators like. You're able to put patients through more efficiently, but at the same time you're not affecting their outcomes, and you can clearly demonstrate that. And the other benefits often that come out of it is also to inform you of business cases when you're trying to start new programs or expand your ICU if that's necessary.
There was a question that came up from Bruce Harries. Bruce, go ahead. Your line is open.
Thanks, Shari. So I did have two, but in the interest of time, it reduced to one, I think. So I was going to ask what surprises for the group working on this, and who created it and are now using it. Any surprises? And then the second question is going to be, what are you most proud of in doing this work? So maybe I'll flip to the second one and just say, what are you most proud of in having done this work and continuing to share it with others?
Peter Dodek here. Do you mind if I try answering that one?
That would be great.
I probably have the longest experience with all this. Thanks, Bruce, for participating and for asking that question. I think the thing I'm most proud of is that we actually now understand who we're serving, what's happening to them, both in the unit and beyond. And this is, before it was here we were taking care of the sickest people, but we really had no measurements about what was going on. So, I mean, it may sound somewhat philosophical, but it's not only philosophical, but it also really helps us understand the components of what we do, and then, as Dean has nicely articulated, how we can start working on individual improvement projects. For example, we introduced electronic order entry in our ICU some years ago for some of our services, and we use that database to help us understand the effects of this introduction on processes of care for our patients, and we actually published that as well. So that's one thing that we've used it for. We've used it at a system-wide level to understand, that we actually admit more men than women to ICUs, even after you adjust for many factors. So that's been a very provocative finding. We've used it to understand relationships between organizational culture and size of ICUs and other characteristics of ICUs. So those are some system features. And then, for those people who are just who are in smaller ICUs, for example, this kind of information can help you understand which patients should stay in your ICU and which patients should actually go to other units. And in fact, that's something that this critical care working group is trying to improve. That is the efficient flow of patients from primary to secondary to tertiary centers. So I hope that's kind of a general overview of what we're proud of.
Great, thanks, Dr. Dodek. Are there any other questions now, either from people who are joining us through their computers or anybody who is on the phone line only? If there's anyone on phone line only, we're going to briefly unmute everybody so that you can go ahead and speak now and ask your questions. Okay, and I had a question for Shelly, actually. If there are people on the call today who are interested in finding out more or to find out how their ICU can get involved and join this database, how would they go about contacting you?
You can give them my email, my Providence email, or I can certainly give my phone number right now. Whatever is the best way, Shari, from your perspective. But certainly feel free to contact me, absolutely. We're very much interested in moving the database forward and getting as many sites on, sharing all the work that we've done. We've put in quite a substantial amount of work into this database over the past, since 99, 2000, and frankly, we're very proud of it. So we're more than happy to share that information. So Shari, I can send you my email and phone contact, and you can send it out to the people afterwards, or however we do that.
Okay, perfect. Actually, one of my last slides, I'll show you where to find my contact information after the call, and you can certainly get in touch with me, and I can put you then in touch with Shelly or anyone else on our panel today. So if there are no other questions, I'm going to just flip back to my slides here and just tell you about a couple of other webinars that we have coming up to support critical care improvement. Coming up in February, we're hoping to have another webinar talking about how you can choose and adapt an ICU glycemic control protocol. And that's based on some of the data that we expect to be collecting through clinical care management. In March, then we're hoping to have another one where we talk about feeding practices and patterns and how those things can affect your blood glucose levels in your patients, and again talking about the use of data for quality improvement and how to improve our practices. And I'd like to direct you now to visit our website, clinicalcaremanagement.ca, where you can find a sign-up link for our newsletter to be informed of our other virtual learning sessions, any other upcoming events. There's information on our upcoming Quality Improvement Forum, which is happening in March of this year in Vancouver. You can also find here the provincial guidelines for glycemic control, the key reportable measures for BC intensive care units around clinical care management, and resources, references, and tools. And you can also find my contact information here as well. So please get in touch if you have any additional questions, anything that you think of after the call today, and want to connect with any of our presenters or panelists. Or if you'd just be more, if you would be interested in becoming more involved in ICU improvement. And a recording of today's event will be available on our website next week. So for those of you who came in late to the call today or just want to review something within the call or want to share it with a colleague, we will have it on our YouTube site as well as a link to download it from this website here that you see on your screen. So thanks so much, everyone, for coming today. It was a great session. I think we all learned a lot. And thanks again to our presenters and our panelists today for joining us for the session.
Thank you.
Thank you.
Thank you. Thank you.